Who are we and where do we work? While many of us have trained as health workers, we also come from other professional backgrounds. We are teachers, social workers, scientists, academics, and technicians. Some of us are volunteers. We receive little or no payment for carrying out health work in our communities. We come from all levels of health systems and are aware of the strengths and limitations of these large and complex organizations and the critical role of political direction and leadership in making these systems work. Some of us lead big teams at national or regional level. Others are responsible for specific areas of work within a local facility or across several facilities. Many of us work with poor communities. For some of the people we work with, healthcare is not a priority above economic activity to survive. The communities we work with may be geographically hard to reach, suspicious of government and by extension us, or hold religious or cultural beliefs that do not easily adopt the science we base our work on. Some of us highlight how decisions about housing, sanitation, and education affect the health of the communities we serve. But decisions on these things are made without reference to population's health needs. COVID-19 has for many of us highlighted the fragility of the systems we work in and our relationships with communities. For some of us, it has meant more investment and renewed political focus on healthcare. For others, it has meant cuts in key budgets and the rise of new threats to our work, such as rumors spread by social media. Many of us remember the fear of the early days of the pandemic and losing colleagues and friends, and often carried out our work without adequate protective equipment. For some of us, this period confirmed why we signed up to work in health. For others, this period was a source of mental stress and anxiety. Each of us is working in a unique context. The nuances of community structures, culture, and religion interact with the structures, image, and resourcing of our health systems. To be successful, we must make this interface work. Those of us who work in humanitarian contexts report further dimensions of complexity in our work. Our security is not often guaranteed. The facilities and equipment that we rely on may be targeted and destroyed, and our target populations may be inaccessible or displaced. Thank you.
Thank you very much indeed. This is the manifesto for Global Health Open Source version 2.0, elaborated by over 1,300 contributions and contributors. I think almost an equal number that have led us to this version 2. Version 1 was presented at Teach to Reach 8 on the 16th of June. And after this Teach to Reach, every one of you will be invited to share your further inputs as we continue to strengthen and improve this document before inviting you to take it before global partners as well as your ministries of health, if that is what you choose to do. Now, this was a preamble to the Women Who Deliver Vaccines Collective, a Teach to Reach special event. This is again following and building on what we did at Teach to Reach 8. The very simple question this time: how have you made HPV vaccination work for girls and women? In a stark reminder, 600,000 new cervical cancer cases each year, 340,000 deaths each year, and backsliding vaccination coverage since the COVID-19 pandemic. So we're going to start and dive in right away now with Charlotte pointing us to our first speaker who is in our Zoom studio, who's been shortlisted on the basis of the experiences shared before Teach to Reach. Charlotte, who shall we hear from on this key topic of HPV vaccination?
Thank you very much, Reda. I have invited Boma Otobo to unmute herself and to share why, because just recently Nigeria introduced the HPV vaccine, and she was a key actor in this process, and we really want her to share how it has been over there.
All right. Boma Otobo, a warm welcome to you. You're a longtime scholar, leader in the movement for immunization Agenda 2030. Do introduce yourself. Tell us who you are, what you do, and maybe also what you did in the past, and then tell us what you'd like to share about this HPV vaccination campaign in Nigeria.
Thank you, Dr. Reda. Thank you, Charlotte. It's always good to partner with you guys. I've learned a lot, and I've also improved on my work. My name is Boma Otobo. I last worked with NPHCDA as the Deputy Program Manager in charge of service delivery at the national level. Shortly after retirement, I got into consultancy with UNICEF, and I'm currently the adolescent health and HPV vaccine introduction consultant in Lagos State. Yes, Nigeria should have introduced HPV vaccine on the 25th of September, all through to the 30th. However, the plan was shelved for several reasons, not because we were not ready, but we wanted the very highest level to be involved. And of course, if at the national level it's not been launched, then the states cannot go on to launch. And so for that reason, it was shelved to the 24th of October. And so we'll be having the 16 states that are in the first phase launching anytime from the 24th of October. And maybe just 4 states amongst those 16 states would also launch, I believe, the following week. And so for us, the target is 9 to 14 years. We've done the micro plan in Nigeria. We've been able to get our HR requirements sorted. Logistics have moved, especially the vaccines, devices, AEFI, because going to involve vaccinations, all of those arrangements have gone on. We also had what we called a rapid assessment, where we went into the communities, more like a research. We tried to find out the knowledge of the community members, school teachers, and so on, how they are able to understand what we're about to do. And we planned for 2, but the outcome of the first one showed that we still needed a lot of work to be done. And so the state and the LGs went back to the grassroots in engaging the communities, ensuring that we're carrying along the schools, sensitizing them, the mothers, the market women, different religious groups, traditional groups. All of these are ongoing. Presently, we are battling with a myriad of rumors against the HPV. And so we've rolled out the risk communication plan at all levels, where we are engaging people who are learned and also showing them the importance of the HPV vaccine. Like you rightly said, Reda, Nigeria records about 12,000 cases plus, where over 7,000 are losing their lives needlessly to something which can be prevented. So when you confront them with such data, they get to understand the importance of it. And I would like to say that Nigeria is targeting age 9 to 14, not because that's the most effective age for now, because we have the vaccines will not go around to the larger population that we love to target, and also for girls, because we're targeting the elimination of cervical cancer. And so the age 9 to 14 are our initial targets, because we believe that the girls have not been exposed at this point to the virus. And so as time goes on, we'll roll it out into the routine immunization schedule as from 2025. On this note, I would like to stop because I understand other speakers are here too who want to contribute. We're using the strategies of the schools, visiting the schools, and we'll also visit out of schools where we'll have girls within our target population in the markets, in the hairdressing salons, in the communities, churches, mosques, and so on, several places where we can find them. And we'll have the routine, that is, anyone that is missed during the campaign will now go into the public health facilities where we have the vaccines available and they can access. But at the public health facilities for the introduction, yes, you can get up to 9 to 14, but thereafter from 2025, it's going to be purely routine where each time can access it.
Thank you very much
indeed.
indeed.
The media, they've done a lot of work for us. So thank you.
Thank you very much indeed, Boma Otobo from Nigeria. Obviously, a major campaign with a lot at stake around HPV vaccination. I'd like to turn to our guide on the side today, Laura Shimp. She is the director of the Immunization Center at JSI. Laura, good morning to you. Question for you. Now, you just heard Boma Otobo, who is involved from the national level. We're going to hear some very local perspectives next. But before Teach to Reach 9, you shared a quote in which you challenged Teach to Reach participants to get very specific about the discussion around HPV vaccination in order for that discussion to be useful. Can you first introduce yourself to everyone, and then who does not yet know you, and then tell us what is it that you're specifically interested in around this question of HPV vaccination?
Thanks so much, and hi everyone for joining, and my apologies to the Francophone team. Hopefully, they will have also a good, rich discussion. Like Reda, I speak French and English, and I have an affinity for both language groups. Right. But for HPV vaccination, particularly what we're seeing, and so I'm a immunization director for the center that provides technical support across many countries. We've helped with HPV vaccination introduction in at least 10 countries, including providing some support for the Nigeria rollout that's happening now, that was nicely described. So for me, I think a key aspect for the HPV vaccination, and I put some resources in the chat that hopefully will be helpful from the WHO collection of resources. What's really important is, as the previous speaker was saying, is to understand local context, to be able to really have that overall political will. And that political will needs to come from not just politicians, but also the other groups and partners who can be very critical for providing messages around cancer prevention, how we work with adolescents and adolescent health, the different partners that we can bring in from, for example, gynecological associations, particularly gynecologists who see HPV in their practice and can speak as testimonial to how vaccination can really help prevent HPV. So what I really would like to hear also from participants, particularly, I know there are several countries on here that have already introduced, like Cameroon, Zimbabwe, Tanzania, Kenya, to hear from them where they're seeing, particularly with out-of-school girls or with populations that may have had many questions about HPV vaccination, where have they been able to really turn that around to have confidence in vaccination, get youth advocates and cancer prevention advocates to really help us identify and reach those individuals who may have had concerns or not understood the vaccination previously, who now are part of the system and being advocates for us. I saw someone in the French chat mentioned the use of mother advocates for vaccination. It would be nice to hear some stories of girl advocates for vaccination and the types of, like I said, the cancer prevention testimonials and others who have really been able to build that confidence and trust and work with the vaccination program to reach people.
Thank you.
So thank you, and thanks to everyone for participating.
Great, thank you, Laura Shimp. Now, we're going to dive in now and remind everyone about the duty of concision, because there are so many, guests of honor who have prepared to speak, who've shared remarkable experiences that speak directly to some of the questions that Laura mentioned. For example, Zuhura Gaki Ahmed, your microphone is unmuted. And we have as well the story that you shared ahead of Teach to Reach. You said you visited women's groups and you talked one-on-one with parents, making them feel that they are part of this exercise. Now you're a community health worker working in Meru, in North Imenti North Municipality. A warm welcome to you, Zuhura. I hope you're going to be able to speak to us so we can hear your story.
Thank you, Mr. Reda. My name is Zuhura, as you have said, Zuhura Ahmed, and I'm very happy to be in this forum today. I've really done my best to make sure that our girls get vaccinated to prevent cervical cancer, that which affects most who have never received the vaccination. In fact, I had a challenge in some families whereby the parents were negatively accepting to this thing. They didn't want to accept on vaccination in misunderstanding, thinking that this vaccination is for family planning, which of course is not. So I had to talk to them and make them understand that this is for prevention of cervical cancer. And to my country, this pandemic, I might call it pandemic, because a high percentage of women are getting cervical cancer. So I had to talk to them one-on-one, make them understand
Zuhura,
that this is.
Could I ask you, when you were with a mother or her daughter, you'll tell us which one. What were the words you actually used? Can you just tell us, model for us, what did you actually say that turned out to be effective in helping people understand and move towards acceptance?
Yeah, I told them that this is not family planning as they thought. So I made them understand that it is a vaccine that prevents cervical cancer. And that's how they came to agree to what I told them.
Okay, yeah. And why did they believe you? Can you tell us a little bit about the relationship you had with these? And were you speaking to the mothers or the girls themselves, or both?
Both, the mother and the girls. I talked to both the mother and the girls, and tried to drive this understanding to them that this vaccine is of more help to them than what they think.
When you say,
I gave them an example.
Yeah.
I gave them an example of a certain lady who had this problem, and when she was asked whether she had ever been vaccinated, she said she had never been vaccinated. So I had to give them the example to show them this vaccine is more important, or it is important for each and every one of us to be healthy, and to keep the disease at bay, the virus at bay.
So let me ask you this question. When you say I made them feel they were part of this exercise and we interacted freely, can you tell me what you actually did to make these women and their daughters feel that they were part of this, involved in this HPV vaccination effort?
Yes, it was about talking one-on-one, asking questions. They asked me questions, I answered their questions. That's how I made them feel that they are part and parcel of the conversation.
Thank you. All right, I'd like to turn now back to Charlotte. And thank you very much. I think we have to mark a pause here just to solve a technical issue. And thank you, Zuhura Gaki Ahmed. I believe next we'll be hearing from Tafu Rother, Muhanja Mutange. And just solve the technical issue. So, Tafu Rother Mutange, I hope you're able to unmute, and then we'll. All right, as we have your story ready, I hope that you are ready as well as one of our guests of honor for today's session. All right, looks like Tafu Rother is not able to respond at this time. Let's have a look in the chat. So we have some great, wonderful messages and dialogue already happening here. And Mary Juma says, well done, Zuhura Gaki from Meru. Dr. Opi Kansal is unmuted, Charlotte. So Dr. Opi Kansal, please introduce yourself and tell us what would you like to bring to this discussion.
Hi, greetings to everyone. I'm Dr. O.P. Kansal from New Delhi, India. I have just joined as country advisor for American Cancer Society for India, and I just want to share. Firstly, let me introduce myself a little more. I'm a medical doctor with a public health background. Uh, from 2000 to 2011, for 11 years, I have intensively worked in the immunization, working in polio eradication, and then the routine immunization in different arenas, including urban and rural, and also at the national level, acting as a national trainer in India and all parts of India. Thereafter, I switched gears for injection safety, infection control, etc. So I was away from immunization, but I'm excited to be back into the arena of immunization. So here, in the current context, where in India, HPV, the cervical cancer, it's around 1/5 of the global burden, both in terms of the new cases as well as the deaths that is happening. And the update is that the government of India is still considering to introduce it at a nationwide as a part of the free under the universal immunization program. But in parallel, the organization like American Cancer Society, along with many other local non-governmental organizations, have rolled out an evidence-based communication material as well as scientific training material, which we called as no, the HPV vaccination, the science of HPV vaccination. So the project that we have rolled just around on 28 September is that the doctors, especially with the background that the medical doctors also themselves do not promote the HPV vaccination or HPV screening proactively. I mean, there are so many opportunities which are getting missed. So to motivate them, to give them a confidence about the vaccine, a large program of training the doctors in India has been rolled out. It's a virtual training program by the two biggest organizations like Indian Academy of Pediatrics as well as the Federation of Obstetrics and Gynecology Society of India, or shortly called as FOXY. So because gynecologists and the pediatrician are the first touch point for a lady who's likely to have a cervical cancer or a similar look-like symptoms, as well as a young child, 9 to 14 years of girls, who are the target age audience for the cervical HPV vaccine. So in summary, this program has been rolled out and it's in just around a week, but really, really good excitement that we are seeing among the master trainers who are getting trained. It's a virtual training program for leveraging fully the available technologies post-COVID across India. And we are pretty excited that over a period of time, there'll be a fundamental difference in the knowledge and awareness of the doctors, which in turn will lead into the mass awareness among the public and the HPV vaccination coverage rate, at least in the private sector, those who can afford will go up. We are hoping, and let's all pray that the government of India agrees in to roll it out very soon. All tools are ready. It's I don't know why. I mean, there are some reasons that the nationwide rollout is still on hold.
Thank you
And
very
I
much,
wish
Dr.
you
O.P.
good
Kansal.
last thing, I wish to just good luck to so many countries that have been hearing that they have already rolled out, and good luck to you. We hope to learn from your experiences going forward. Thank you so much.
Wonderful. Now, Tafu Rother Mutange, who I was trying to get earlier, is now has a microphone unmuted. Mutange, I hope you are ready and able to speak to us, as you are one of our guests of honor. Tafu Rother Mutange, are you able to speak to us? I can see your microphone is unmuted, but we still cannot hear you, unfortunately.
Hello.
Yes. Okay. Wonderful. So good to finally hear your voice. You are a community health worker working in Kangemi around Nairobi,
Yes.
At a health facility, and you wrote about church leaders and school teachers helping persuade reluctant parents when it came to HPV vaccination. So you said, though most of the people were afraid of the vaccines, I had to use my time to talk to the people in the community about the importance of the vaccines. Some people started to listen and allowed their girls to be vaccinated. I was helped by my church leaders and also school teachers. With this teaching, they started responding one by one. My first question to you is, when you had time to talk to people in the community, can you tell us what words you used? What did you actually tell them that helped them understand the benefits, the safety, and efficacy of HPV vaccination?
Yes, I first have to humble myself to have this opportunity to talk to you, Reda, and the health professionals all over the world. I used my time to go to church leaders and school teachers to organize for me people, parents, especially parents, to talk to them about the HPV, because at first they thought it was going to make their children, girls, to be barren, and the young women to be barren, not to give birth. But I had to talk to them, use sweet words. I told them it was important because it was just going to make them not to get cervical cancer. And that's how I thought. Sorry.
No, that's just some. Please proceed. We're listening.
So I talked to them. I told them the importance of getting the vaccine because it was going to prevent their girls and young women from getting cervical cancer. So I taught them how to go about how to prevent them, their children, because they had a negative thought that the children and young women are going to be barren after they have been vaccinated. But at long last, they accepted, and though they have not vaccinated all of them, but some of them have been vaccinated, and the others are still ongoing. So that is how it came. It came to give a positive solution to the problem.
Thank you very much indeed, Tafurulder Mutange from Kangemi, Nairobi, Kenya. All right, we are going to keep going to hear a few more experiences shared. Charlotte, who shall be next? We want to keep in mind the balance between countries and genders as part of our rules of engagement for Teach to Reach. Charlotte will tell us who we're hearing from next, and then we'll go to Laura Shimp, who is our guide on the side for this session.
So Akelo Rebecca already has her mic open.
All right,
we'll
wonderful.
We'll just guide you.
Yes, Rebecca, a warm welcome to you. What do you wish?
Thank you. Greetings to everyone. This is Akelo Rebecca from Uganda. I'm a public health nurse, and I'm directly involved with immunization in Kumi municipality in the health center 4. Yeah, previously in 2021, after the COVID, there was a lot of hesitancy in a vaccination generally, including HPV. But and that is the very time we had a rise of teenage pregnancies. So I used data of teenage pregnancies, and I visited the education municipal officer, and then I shared with her that we needed to intensify school health. And one of the things that I had in mind to do was to do HPV vaccination, and then TD, that is tetanus toxoid, previously known as tetanus toxoid, and then also to educate on teenage pregnancy, its effects and the complications to a girl child. So when we had a dialogue with the municipal education officer, we zeroed down that we invite all the head teachers of the primary schools and the secondary schools within the municipality for a meeting. And when we had that meeting, it was so successful that we drew up a schedule. Each head teacher gave me an appropriate date to visit the school. And indeed, we organized the schedule, and we implemented that. And every school I visited with my team, we had all those services given. First and foremost, for them to accept the vaccination without the consent of the parents, it was difficult. So during the AGMs, they asked me to go and give a talk on HPV vaccination and any other adult vaccinations related to the children, because they get consent, they get them before the parents even consent, since it is a school program. So when I talk to the parents in AGMs, they openly said it's okay as long as you know the vaccine has no problem. But others still said, I think we hope you're not bringing COVID vaccine, because they were really against COVID. But after a long explanation, I had to draw for them the uterus and locate where the cervix is and how the vaccine will prevent the cervical cancer. They really appreciated the science behind that. And now we penetrate the schools, we do the vaccination without any hesitancy. And that is my success story in the municipality. Even right now, we are implementing integrated child days plus. So where we go with HPV, tetanus, diphtheria vaccine, and then also other educational topics to do school health as well as vaccination. Thank you very much. Back to you, Reda and Charlotte.
Thank you very much indeed, Rebecca Okello from Uganda. Yes, back to you, Charlotte.
Okay, thank you very much, Reda. So in terms of gender and geographical equity, I think we'll listen to, Anu will listen to Michael Jones, and then we'll end with Anu just afterwards.
There's also Dr. Suresh Shukla.
Yep. Thanks, Charlotte and the team. So for us here in Sierra Leone, the HPV introduction was really a successful before the introduction. And then we had real engagement, and we decided to have the HPV introduction as integrated introduction. Intersectoral engagement, the Ministry of Education was involved, Ministry of Local Government was involved, and then the Ministry of Gender was involved. And then we all collaborated together in the rollout of the HPV vaccine. And we ensured that the integration, the sensitization and orientation goes down to the chiefdom and the village level, wherein we engage at all level tribal heads, we engage local and traditional leaders, and we engage women, influencers, women in the various districts. And we established technical working group in all of the districts, which coordinates the HPV rollout and the introduction. And then when we faced with the situation where we didn't have enough money to roll out the HPV vaccine across the country, we decided that we should integrate HPV with COVID-19. So that was the first time we did an integration of COVID vaccine. So we use HPV vaccine and COVID-19. We integrate it alongside vaccinating girls at 10 for the HPV vaccine, and then of course vaccinating boys and girls at 12 for the COVID vaccine. And then this was a very, very successful introduction, and we even had achieved the coverage more than what we were expected, the targeted number what we were expecting. And we used to approach school-based vaccination, where we go to schools, engage the teachers, and get the teachers line up the kids and get them vaccinated. Then, of course, we use the CHW at community level in identifying and line listing girls who are at targeted age 10, and then get them assembled at critical location, and the vaccination team comes and vaccinates them. We are able to have issues related to refusal, especially those from the private school, because we earlier engaged the Association of Private Schools, and the first girl who was vaccinated was a girl from a private school. So that sends a clear message to the private schools who normally refuse vaccines or refuse access of health care to their schools, and then giving us the room to come in and get the kids vaccinated at the schools. But in a nutshell, the success of our story is because we decided to integrate HPV and COVID-19, and we're able to have a greater impact in terms of having girls vaccinated with HPV vaccine at 10 years in schools and out of schools, and then of course boys vaccinated with COVID-19 vaccine at 12 years in school and out of school. And then this is a story that we would love to tell, and this is something we've enjoyed, we've seen. Then after the introduction, we decided that HPV should continue to be part of the routine. But then we tried to include it part of the outreach sessions that the facilities will go to community and schools. But then in our periodic intensification of routine immunization, the PURI, we added HPV as part of the routine vaccine, which should be should be taken along with healthcare workers when they are going on their outreach to communities, especially in identifying zero-dose children. HPV vaccine was part of it, and they were able to reach out to us at school. As part of our PUE exercise, we've vaccinated over 50,000 girls with HPV vaccine since the introduction. And at the introduction, we are able to vaccinated over 170,000 girls in school and out of school. So this is a good strategy that we use in introducing HPV. Over to you, Charlotte and Red.
Thank you, Michael Jones. Now, we heard about Sierra Leone's HPV vaccination success story at Teach to Reach 8. So we're glad to hear this follow-up, and look forward to hearing more as you maintain and continue to grow your efforts, and to continue learning from that. Thank you for joining these sessions. Now, Dr. Suresh Shukla has been sending messages. Dr. Suresh, we'd love to hear your success story, lessons learned, or challenge around HPV vaccination. We've obviously gone over time. We knew this would happen. We should have I just forgot to announce it, to say we'd be spending a little bit more time than the 30 minutes initially allotted on this question. I also want to acknowledge, before we hear from Dr. Suresh Shukla, the many mostly greetings. So please, we're asking specific questions, success story, lesson learned, challenge around HPV vaccination, but we are getting some right now we're getting mostly greetings. So Patricia, Ido Collins, Husseini Garba, for example, Asad Ali, Abdullahi Mohammed Takai. Really, the point is for you to share your experience once you have said hello, of course. Now, Dr. Suresh, over to you. What is the success story, lesson learned, or challenge that you'd like to share about HPV vaccination? And just as a reminder, this is not about general opinions about the subject or theory about the subject. This is really about things you have actually done, carried out, and what you learned from that. But please do introduce yourself first.
Good evening, everyone. I am Dr. Suresh Shukla, working as a surveillance medical officer in the World Health Organization, IPD. I've been working since 3 years. This is the first time our country demonstrates HPV vaccination, and there is few amount of vaccine.
Sorry, can you tell us which country, Dr. Suresh?
Nepal, 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 Nepal.
Thank you.
Yes, sir. Let's go. First of all, when we in the process of introducing the vaccine, there are a lot of rumors in the community. So first we catch the governance, like local government, provincial government, and federal government, and advocacy with them. After that, we move towards the school teachers, like some district authority, provincial authority, and advocacy. Have a meeting, orientation, technical as well as practical things, and other country research, how they succeed. After that, we are planning this vaccination in the tertiary level hospital, because many people afraid that maybe AFI comes more. So we start from the tertiary level hospital. Every province, one hospital we choose and announce. First of all, we give priority on the media communication. How to get communication up to the community people or school children who are the targeted group. And our program, we are just providing the 14 and 15 years, just that age group of females. And these things, even when we start the campaign, 1 or 2 days, there was 5 days campaign in whole country, and 2 days in tertiary level hospital, very few client comes for the vaccination. Then we have changed the plan and moved towards the community and educating more community people. And we use, our country have the female child health worker who is supporting in the immunization program as well as nutrition and other, and they are counseling with the females who are not going to school. Children comes from the school, but those living in the community, these female child health worker are bring them, and we are getting success to give vaccination to that age group of females and the girls, and there is no any AFI. And very good story. First, we need to media communication and orientation to health worker first, and the leaders group like some religious groups, religious leader. We find some religious groups, they are totally denied to get this vaccination. There is a bad rumor that before marriage taking this vaccine, something rumor like that. When we catch the religious leader, we counseling them, advocacy them, then we found that things, faith healers, traditional leaders, and to reach the community, we are apply that type of our planning, and we get success in our HPV vaccination our country, and we get good success and coverage. Thank you, sir.
Thank you very much indeed, Dr. Suresh Sukla. So we are over time with this session. I do also want to go back to Laura Shimp, our guide on the side for this session, to hear really, it's going to be difficult to give us a concise synthesis, but maybe the three key takeaways from the discussion so far. We'll hear maybe from one other person, and then we'll be shifting over to the topic of measles outbreaks. And if this leaves you thirsting for more, that is exactly what we're hoping, because the heart and soul of Teach to Reach is not in these plenary sessions where you'll hear just a few people speak, but it's in the individual networking that will be opening up after this session, and you can join. You can choose or alternate between networking and plenary sessions. Again, to demonstrate how this works, you go to the speed networking, and then when you're ready to meet someone, you click on join. I tried to, but didn't succeed in demonstrating that in the tutorial session, but it does work, and we've seen hundreds of participants actually join these networking sessions. So Charlotte, maybe one more person, and then and asking that person to be especially concise, and then we'll shift. We'll ask Laura for her three key takeaways. Charlotte.
Right now we are going to end with Anu. Sorry, Darius, it's gender equity at play.
Okay. All right. So greetings, everyone. Thank you, Charlotte. Thank you, Reda, for this opportunity to share my experience on HPV vaccine in Nigeria. So just adding to what Professor Boma has said again is that one of the good things that Nigeria has taken on is the inclusion of the civil society in the advocacy and mobilization.
Sorry, Anu, but I don't think you've told us who you are or what you do.
Okay, so my name is Anu Rotimi. I'm joining from Abuja, Nigeria. I'm a civil society practitioner. I'm a immunization advocate, and I keep on advancing attainment of universal health coverage. So yeah, thank you for that. Sorry, I missed that part. So in addition to what Nigeria is doing in terms of the high-level political mobilization, integration into the PhD advancement, is also the inclusion of civil society in the advocacy and mobilization and sustainability of the uptake of the HPV vaccine. And thanks to Gabi, we are working with partners such as the Women Vaccine Advocacy Group, the CSOs around the country, and especially in the first 16 states. Were selected, some were selected and trained, and some of these CSOs were also expected to step down to training to the other civil society. And the CSOs were actually equipped with some IEC materials to help disseminate information around HPV. So one of the things my own organization were able to do is that we are working closely with what we call the World Development Committees and the women associations and parent associations, because we know that girls between the age of 9 to 14 require parental consent to take any form of vaccine. So even as much we're also informing them at schools, we're also reaching out to the parents on guidance to give these children the right to take the vaccine. So one of our learnings is like there are already some misinformation made around the vaccine, around that, is it going to prevent fertility and the rest? But we made them clear that the vaccine is safe, and we also use this slogan that vaccine is good in our awareness and mobilization campaign. So also, one thing that has also worked very well is that we don't go to them and tell them, come and take vaccine. We share the experience from first. Do you know about cancer? What do you know about cancer? What type of cancer do they know? And if they mention cervical cancer, we now dwell on the cervical cancer as well, in as much as there are different types of cancers, but we are lucky that this particular type of cancer, which is cervical cancer, as a prevention mode, which is actually preventing girls from actually the HPV virus advancing to cancer at a later stage in life. So they have the opportunity right now to prevent the young girls from cancer, so we can have a future generation that is free of cervical cancer. So that message is actually resonating so well with the community, with uptaker, with girls, with the parents. And in fact, the concern now is that they're now feeling, why won't even older girls also have access? Why won't older women also have access? So they don't have to also be victims of cancer. Also, they're also advocating. One of the people we are getting back from the community is also
to ask you to
include
conclude,
boys
please.
and girls, to include
please
boys
conclude.
and girls in the vaccination. Thank you so much.
All right, thank you, Anu. Super interesting, but again, we have so many people who are waiting to speak. I again you call on your duty of concision out of respect for fellow guests of honor and speakers who are here. And I'm going to ask the same thing from our guides. So first, Laura Shimp, if you could share 2 or 3 concise takeaways from this, from the many different. I'm sure we could spend hours more discussing, but that is not how the learning process actually works. We're going to mark a pause here with feedback from Laura, and then Deepa Pokharel from UNICEF, ahead of our zero dose session, but very much involved, who leads demand for vaccination at UNICEF, also will have some feedback for participants. So Laura, 3 takeaways, and then Deepa, concise feedback for everyone.
Thanks so much to everyone. Great contributions, and I'm sorry that we can't hear every one of them. I think we could be on for 3-4 hours. 3 main takeaways. One, the great examples that have been shown about the importance of having girl advocates and peer-to-peer learning between girls, so that those who've been vaccinated or those who know more about vaccination can help convince and console the other girls. No one likes injections. So, help to address the protection and other things. And secondly, the importance of working with cancer prevention groups to really help people understand this is an incredible cancer prevention vaccine. Like, we have a way to prevent a cancer. And, trying to get people motivated about that, because HPV is such a killer of our women and mothers and others. We want to prevent it. And thirdly, the important aspects that were mentioned around linking with ministries of education, religious groups, and others who can help us link with communities best and link with schools, so that we have a holistic approach. Immunization can't do this alone. We saw that with COVID also. So really being able to have those long-term partnerships with those who can help us reach the communities that trust them. Thanks.
Thank you very much, Laura. Over to you, Deepa, and please do briefly introduce yourself. You'll be our last person to speak on this topic, as we're shifting to measles outbreaks, and equally, without wanting to compare which one is more urgent. Deepa?
Thank you, Reda, and thank you, colleagues. It's been an incredible session. My name is Deepa Pokharel, and I am with UNICEF headquarters. I lead the vaccine demand work for UNICEF at headquarters. And as obviously HPV is one of the things among many other things that UNICEF supports across 150 countries across the world, including many of your countries, which you've already mentioned: Kenya, Nigeria, Uganda, India, Nepal. So just a couple of points. It's been really educational to hear the real experiences from colleagues. I wanted to narrow down on a couple of things. Some of you touched upon the need to have rapid assessments, but I think it's a very important start to, when we say data, we don't have to think of a CAP survey, which takes like a long time, but really listening to what the girls have to say. What do the mothers and the community leaders have to say? What are their concerns? Because that's the starting point. When we start looking at co-creating solutions, which is informed by the local data, I really want to ask and request the participants who have spoken. I'm sure that you're already doing it, but just to emphasize, it's so incredibly important to hear from these young people because they have a mind of their own. So here, HPV vaccine is a life course based vaccine where we are dealing or we are working with 2 or 3 different populations. Normally, we would just talk to caregivers, but in this case, the young girls, as Laura already mentioned about how do you actually engage girls. And there's a tremendous amount of work that is being done at the country level, community level. The second point I wanted to touch upon is misinformation. Like in every other new vaccine introduction, HPV also comes with a fair share of, actually even more than other vaccines in terms of misinformation. So we do need to be ready to have a system in place where we have a mechanism to listen to communities and address them really quick, in a quick turnaround. I'm not talking just about the social media, but also the community conversations from different people who are talking about it, and then have our influencers, which many of you already touched upon, about whether it's pediatric association, whether it's religious leaders or communities. And the third thing I really wanted to ask is, based on the community engagement tactics, which has been used by many colleagues across the world, and some of the fantastic things that we heard. Mass media is one thing which can create an enabling environment. But when you are talking about uptake of the vaccines, media engagement is not the only thing which is going to work. That's what the experience shows and the data shows. So I really encourage that we engage our communities right from the beginning, from the time when we are collecting data to the planning and then implementation. But thank you so much, colleagues, for the wonderful work you do across the world. And it's really been such an educational experience. Thank you, Reda. Over to you.
Thank you very much indeed. Deepa Pokhrel will be joining as a guide on the side for our 0 dose session, but is very much involved in these issues of